Assalamu alaikum, sir.
Sorry.
Sir, can I start?
जी please.
Okay. Female incontinence non-surgical management EAU guidelines. Introduction. Urinary incontinence is an extremely common complaint in every part of the world. It causes a great deal of distress and embarrassment as well as significant cost to both individuals and society. Estimates of prevalence vary according to the definition of incontinence and the population study. However, there is universal agreement about the importance of the problem in terms of human suffering and economic loss. The aim and objectives for these guidelines and publication. These guidelines from the European Association of Urology was urinary incontinence are written and multidisciplinary group, primarily for the urologist and are likely to be referred to by other professional groups. They aim to provide sensible and practical evidence-based guidance on the clinical problems of urinary incontinence, rather than an exhaustive narrative review. Such a review is already available from the International Consultation on Incontinence. And so the EAU guidelines do not describe the causation, basic science, and psychology of urinary incontinence. The focus of these guidelines is entirely on assessment and treatment reflecting clinical practice. The guidelines also do not consider patients with urinary incontinence caused by neurological disease or in children, as this is covered by a complementary EAU guide. The current guidelines provide a clear pathway algorithm for common clinical problems. This can provide the basis for patients management and also for planning and designing clinical services. A brief but authoritative summary of the current state of evidence on clinical topics, complete with references to the original sources. Clear guidance on what to do or not to do in most clinical circumstances. This should be particularly helpful in those areas of practice for which there is little or no high quality evidence. So, medical management will start from diagnostic evaluation. The very first step in diagnostic evaluation is history taking and physical examination. We should be taking a careful clinical history as it is fundamental and should be the first step in assessment of anyone with urinary incontinence. The history should include details of type, timing, and maturity of urinary incontinence, associated voiding, and other rumors. History should allow urinary incontinence to be categorized into structural incontinence, urgency urinary incontinence, or mixed urinary incontinence. It should also identify patients who need rapid referral to an appropriate specialist. These include patients with associated pain, hematuria, recurrent urinary tract infection, pelvic surgery, most particularly prostate surgery therapy, a constant leakage fistula avoiding difficulty or suspected neurological movement, and obstetrical and gynecological history may also help to understand the underlying cause and identify factors that may affect complete decision. The patient should also be asked about other ill health or for details of current medications and these may impact on symptoms of urinary incontinence. There is little evidence from clinical trials that carrying out a clinical examination improves care, but with consensus suggests that it remains an essential part of the assessment of people with urinary incontinence. It should include abdominal examination to detect an enlarged bladder or other abdominal mass, the perineal, the digital examination of the rectum, prostate, or vagina. Examination of the perineum in women includes an assessment of the estrogen status and a careful assessment from any associated pelvic organ collapse. A cup test may reveal stress urinary incontinence if the bladder is sufficiently full while pelvic floor contractions together with the urethral mobility can be assessed digitally. The second step is avoiding times. Quantities are a semi-objective measure of quantifying symptoms such as frequency of urinary incontinence episode. They quantify urodynamic variables such as voided volume and 24-hour or nocturnal urine volume. In addition, voided volume measurement can be used to support diagnosis such as OAB or polyuria or epic bladder. These also help us to monitor treatment response in patients with a severe urinary incontinence. However, it is unlikely to accurately report with 4-hour urine output, and so voided volume may be lower than total bladder capacity. And the body guide is having a recommendation which tells us that ask patients with urinary incontinence to complete a body guide. Even standardized assessment is the diary duration of at least 3 days. So these are the recommendations for the body guide in the diagnostic evaluation of female urinary incontinence. Register pseudotypic urinary urinary tract infection. The proteinuria, hematuria, or glycosuria require further assessment and refer to the urological infections guidelines for diagnosis and treatment of urinary tract infection. Recommendations for them to perform urine analysis as part of the initial assessment of a patient with urinary incontinence. If a symptomatic UTI is present with urinary incontinence, reassess the patient after treatment. Run routine treat asymptomatic bacteriuria in elderly patients to improve urinary incontinence. Another point is PVR, which is post-void residual volume, but it indicates poor voiding efficiency, which may result from a number of contributing factors. This is important because it may worsen symptoms and poorly associated with UTI. Upper urinary tract dilation and renal insufficiency. Both bladder outlet obstruction and retrosal underactivity contribute to the development of PVR, post-void residual volume, and can be measured by catheterization or ultrasound. The prevalence of PVR in patients with the urinary incontinence is uncertain, partly because of lack of standard definition of an abnormal PVR volume. And the recommendations for PVR is when measure PVR in patients with UIU who have avoiding symptoms. Measure PVR when assessing patients with complicated urinary incontinence, and post-void residual should be monitored in patients receiving treatment that may cause or worsen voiding dysfunction, including surgery for stress urinary incontinence. Coming to urodynamics, urodynamics testing is widely used as an adjunct to clinical diagnosis, in the belief that it may help to provide or confirm diagnosis. Predict, treat urodynamics is often performed prior to invasive treatment for urinary incontinence. These guidelines will focus on invasive testing, including multi-channel histochemistry, ambulatory monitoring, or video urodynamics, and different tests of these, such as visual pressure profilometry, vessel volume, point pressure estimation, and retrograde electoral resistance measurements, or facilitated discussion during count. For all these reasons, and the recommendations for urodynamics are that when performing urodynamics in patients with urinary incontinence, they have a good urodynamic practice standard as described by International Continence Society. And they are attempting to replicate the patient's symptoms, check recordings for quality control, and protect results in contact. The clinical problem, remember, there may be physiological variability with the same individual. And do not routinely carry out urodynamics when offering treatment for uncomplicated stress urinary incontinence.
So just a word about urodynamics here. You see, we were discussing this issue when urodynamics was, I think, presented by Mohsen also. You have to have a question. That was my recommendation, sort of recommendation for myself. Unless and until you have got a question, and that question will always arise when you have got a patient, you have done with the history. You are actually in the process of thinking of what is the actual root cause of the problem, and the problem is maybe incontinence. So in order to classify urinary incontinence, you have to go broadly first, meaning to say, for instance, overflow incontinence or urge incontinence. So before directly going on to urodynamics to give you it won't give you a diagnosis, but it can lead you to diagnosis. Since it cannot give you the diagnosis, you must have got a differential at the back of your mind. Now, how you make a differential diagnosis? For making a differential diagnosis, you have to go through history and then a little bit of what they have recommended, a kind of a thing which is known as bladder diary. Whether it's a male or a female, if the problem is something related to bladder function or dysfunction, you must know what's the kind of daily activity of the patient, what is the daily activity of the patient is. For instance, how much water is the person taking and how much and what the frequency of urination is. So that is what bladder diary is. It is just a charting of input and output in relation to the timing. So for making yourself understandable of the 24-hour situation in which the person is actually living, he or she might not be in the house confined to a room, or he or she might be working somewhere in the field, somewhere in the community. So you must know what is the normal daily routine of the patient of taking in fluid and making urine, and the urine is going out of the bladder. So this is what the diary is. So before directly going towards urodynamics, you have to have that kind of assessment first, because that will make your mind working in the direction of actually putting up a question for yourself. So when you put up a question for yourself, then you actually is going towards having an answer. So that is the kind of strategy that one should have. Yes. Please continue.
Another investigation includes the paracastic measurement, which tells us about the measurement of urine loss using an absorbent pad worn over a set period of time or during a particular exercise, and strategy of generating incontinence as well as patient's response. So these are the recommendations for a backup as for the backup question directly and activity protocol. Use the backup when quantification of urinary incontinence is required. Imaging includes the imaging improves our understanding of the anatomical and functional abnormalities that can cause urinary incontinence. In clinical research, imaging is used to understand the relationship between anatomy and function with condition of the central nervous system or of the lower urinary tract and urinary incontinence, and investigate the relationship between lower urinary tract and pelvic floor imaging and treatment outcome. Ultrasound and magnetic resonance MRI have largely replaced X-ray imaging. Ultrasound is preferred to MRI, but of its ability to produce three-dimensional and four-dimensional dynamic images at lower cost and wider availability. Studies on lower urinary tract imaging in patients with urinary incontinence often include an evaluation of surgical outcomes, design and conduct these trials. The recommendations are about the routine carry out imaging of the upper or lower urinary tract as part of the session of urinary incontinence. Disease management, non-surgical. So coming to the conservative management of the female urinary incontinence. In clinical practice, it is conventional that non-surgical therapies are tried first because they usually carry the least risk of harm, and they are often used in combination, which makes it difficult to determine which components are effective. Containment devices play an important role, especially for the individuals who prefer to avoid the risk of interventional treatments or who active treatment is no for any reason.
Now, just a minute. Just a minute for.
Yes, sir.
Just a minute for making everybody in the classroom understand the concept behind conservative management. Now here is an opportunity and a way forward for ourselves, the third world country like Pakistan. You see, we have got our own problems, we have got our own economic constraints. If we want to practice something which is of a value and of a caliber or status that has been practiced in the Western world, perhaps, or in the developed world, then we are far behind. So for every aspect of urological disease, perhaps, there is always a place for conservative management, or a place for something called non-interventional management of the disease. Particularly in this case, female incontinence, this is so important that in our, for instance, setup, if we have got a patient who has got incontinence, if we want to try to put in something called artificial sphincter, then that is very near to impossible because of many different aspects to this therapy. One of them is the cost. The second one is the availability of the device. There is not much market, so there are no marketing agencies here. So there are many different problems which are beyond the ambit of a doctor or a urologist working in an institute. So for us, this subject of conservative management is actually more important as compared to a person who works in a developed world hospital. So if we try to figure out ourselves what is the place for our patients with their own specific problems, and how we should just apply all these different informations related to conservative management, then I think almost more than half of the problems can be solved by this strategy. So at least we are not shying away from the actual problem that the patient has, and this is something which relates to a lot of psychological diseases which are related to incontinence, perhaps. So I think this is very important, more important to us than to anybody else. Yes, please.
Simple clinical interventions which include underlying disease, cognitive impairment, urinary incontinence, especially in the elderly, has been associated with the multiple comorbid conditions including cardiac failure, chronic renal failure, diabetes, chronic obstructive pulmonary disease, neurological disease including stroke, and multiple sector losses. General cognitive impairment, sleep disturbances like sleep apnea, depression, metabolic syndrome. It is possible that improvement of associated disease may reduce the severity of illness sometimes. However, this is often difficult to assess as patients frequently suffer from more than one condition. In addition to intervention, may be combined and individualized, making it impossible to decide which alteration is an underlying disease and affected the patient's urinary incontinence. And these are the recommendations for that. Patient with urinary incontinence who has associated conditions should have appropriate treatment for those conditions in line with good medical practice. Coming to the next thing is constipation. Several studies have shown strong association between constipation and urinary incontinence. Constipation can be proved by behavioral, physical and medical treatment. Constipation appears to be associated with urinary incontinence. However, there is no evidence to show whether or not treating constipation improves urinary incontinence. Although both constipation and urinary incontinence appear to be improved by a certain behavioral influence. The recommendations for constipation is that adults with urinary incontinence who also suffer from constipation should be given advice about bowel management in line with good medical practice. Containment is important for people with urinary incontinence when active treatment does not solve the problem, or when it is not available or not possible. Some individuals may prefer treatment rather than undergo active treatment with associated risk. This includes the use of absorbent pads, fluid catheters, external collection of devices, penile clamps for men, and intravaginal devices for women. Studies of catheter use are not specific to patients with non-neurological urinary incontinence. Recommendations for this is to ensure that adults with urinary incontinence and their carers are informed regarding available treatment options before deciding on treatment alone, and offer incontinence pads and containment devices for management of urinary incontinence. Lifestyle intervention. Example of lifestyle factors that may be associated with incontinence include obesity, smoking, level of physical activity, and diet. Modification of these factors may improve urinary incontinence. Caffeine reduction. Many drinks contain caffeine, particularly tea, coffee, and cola. Anecdotal evidence of urinary symptoms being aggravated by excessive caffeine intake has focused attention on whether caffeine reduction may improve urinary incontinence. However, a cross-sectional population survey found no satisfactory association between the caffeine intake and urinary incontinence. Lack of knowledge about the caffeine content of different drinks has made the role of caffeine reduction in elevating urinary incontinence difficult to access. There is a summary of evidence for this, which tells us the reduction of caffeine intake does not improve urinary incontinence, and reduction in caffeine intake may improve symptoms, urgency, and frequency. Physical exercise. Regular physical activity may strengthen the pelvic floor musculature and possibly decrease the risk of developing urinary incontinence, especially stress urinary incontinence. However, it is also possible that heavy physical exercise may aggravate urinary incontinence. The summary of evidence is female athletes may experience urinary incontinence during intense physical activity, but not during common activity. Strenuous physical activity does not predispose women to urinary incontinence later in life. Moderate exercise is associated with lower rate of urinary incontinence in middle age or older women. Fluid intake. Modification of fluid intake, particularly restriction, is a strategy commonly used by people with urinary incontinence to relieve symptoms. Advice on fluid intake given by healthcare professionals should be based on 24-hour fluid intake and urine output measures. From a general health point of view, it should be advised that fluid intake should be sufficient to avoid thirst, and that to low or high 24-hour urine output should be investigated. The summary of evidence tells us that there should be conflicting evidence on whether fluid modification improves urinary incontinence or not. Obesity and weight loss. Being overweight or obese has been identified as a risk factor for urinary incontinence in many epidemiological studies. There is evidence that the prevalence of poor urinary incontinence and stress urinary incontinence proportionately with rising body mass index. The proportion of patients who undergoes surgery for incontinence who are overweight or obese is higher than that of the general population. The summary of evidence is obesity is a risk factor for urinary incontinence in women. Non-surgical weight loss in overweight and obese women improves urinary incontinence. Surgical weight loss improves urinary incontinence in obese women. Weight loss in obese women improves urinary incontinence, and weight loss in obese adults with diabetes mellitus reduces the risk of developing urinary incontinence.
And there is one article recently in British Journal of Urology, or I think in Journal of Urology, and what they have discussed in that article is actually the impact of weight reduction surgery, for instance bariatric surgery, on dealing with obesity, but in a way affecting incontinence. And they have got slightly better position for patients who have been through weight loss surgery, and their incontinence becomes better. They are more continent. What is the relationship? It might not be one-to-one. For instance, it might not be the case that every patient with incontinence who happens to have a BMI greater than maybe 35 if that person has got bariatric surgery, improves. But on a larger scale, on a bigger population, yes, that happens, and it has got its value. So even a weight reduction of not of substantial value but slight weight reduction, even that has got its impact on incontinence. On the flip side, if somebody who is continent, middle-aged, but becomes all of a sudden, maybe in 2 or 3 years, because of many different conditions or situations, becomes overweight or gains weight because of probably borderline diabetes or things like that, the person becomes incontinent. And this is something which you can also experience if you happen to post yourself in the filter clinic of SIUT on any Saturday. If you see patients who have been maybe perimenopausal, when some of the patients do gain weight, they actually complain about incontinence. And if you try to figure out this weight gain with incontinence, and if they lose weight, they become even better. They become better on the actual continence side of the disease aspect. So it doesn't take much on the front of prescribing something. It is just modification of the lifestyle, and again this comes under the heading of conservative management. So whatever we are actually seeing at the moment in different slides, one by one, are those smaller things that can contribute, and if we deal with them, they can actually they can actually be beneficial for the patient. Yes, please.
Smoking. Smoking cessation is now a generalized public health measure and has been shown to be weakly associated with improving evidence difference in the process. And some evidence is no evidence that smoking cessation may improve the symptoms of urinary incontinence. These are the recommendations for lifestyle intervention, which tell us to encourage overweight. Recommendations encourage overweight and obese adults to urinary incontinence to lose weight and maintain weight loss. Advise adults with urinary incontinence that reducing caffeine intake may improve symptoms of urgency and frequency, but not incontinence. Review type and amount of fluid intake in patients with urinary incontinence. Provide smoking cessation strategies to patients with urinary incontinence who smoke.
So you see, many of the things that have been discussed, they are strongly recommended, except for one, and that is the type and amount of fluid intake. Perhaps because the reason that we don't know what is the caffeine content of our different fluids that we drink. But when you come to this part of the world, Pakistan, we are in the habit of drinking not many different kinds of fluids. Maybe on a daily basis, what you drink is water, perhaps milk, tea. That might be with caffeine or without caffeine, meaning to say that you might have got green tea, or you might have got a tea which is the black tea, and which has got more caffeine content. Some of the people, they do have 1 or 2 cups of coffee, but otherwise we don't have that kind of a variation in fluid variety as the West has, because they have got liquors in their own daily routine of fluid intakes. For instance, there are different kinds of liquor that they consume. Maybe a little wine during their dinner meals, or maybe during the daytime they drink something which is like beer. So they have got many variations of different kind of fluids that are actually making their kidneys and their bladders exposed to different kinds of natural and unnatural beverages. What we have got an advantage. More of our fluid intakes are actually natural. They are not unnatural in that sense. Maybe there is one or two exception here and there who can have different kind of beverages. Otherwise, our bladders are not exposed to that kind of situation. So it is rather easier for us to manage our patients and their different kind of fluids that they take. Yes, please.
Behavioral and physical therapies. Terminology relating to the behavioral and physical therapies remains inclusive because of the wide variety of ways in the treatment regime and combination of treatment have been delivered in different studies. The terms are usually encompass all treatments which require a form of self-motivated personal retraining by the patient and also include techniques which are used to augment this effect. Approaches include graded training, TFMT, but such as graded discipline and graded re-education and behavior modification are also used. Almost always in clinical practice, these treatment used as part of practical care, including lifestyle changes, patient education, and possibly some cognitive therapy as well. The extent to which individual therapists motivate to provide a monitored these interventions is likely to vary, but it is recognized that these influences are not important components of whole treatment pattern. Coming to prompted wording, the term prompted wording implies that carers rather than the patient initiate the decision to void, and this applies largely to an assisted care setting. Graded training. A program of patient education along with schedule voiding with gradually adjusting voiding intervals. Specific goals are to correct faulty habit patterns of frequent urination, improve control over greater adversity, prolong voiding intervals, increase graded capacity, reduce incontinent episodes, and restore patient confidence, restoring greater confidence. The ideal form or intensity of a graded training program for urinary incontinence is unclear. It is also unclear whether or not graded training can prevent the development of urinary incontinence. Although graded training is clear for high-intensity program of DFMT, which includes that is what value for muscle training to do stress urinary incontinence in elderly women. Graded training is better than intravaginal facilities to control stress urinary incontinence, although improvement may also be short-term. Whatever the method of training used, any benefit of graded training on urinary incontinence is likely to be of short duration under graded training program. Its practice repeatedly, no adverse events have been reported in graded training. Perhaps effect of graded training increase continence rate and improve mixed urinary incontinence, improve randomized board trials. Coming into pelvic floor muscle training. Pelvic floor muscle training is used to improve the function of the pelvic floor, including urethral stability. There is some evidence that improving pelvic floor function may inhibit graded contraction patients with overactive distended bladder. Pelvic floor muscle training may be used to prevent the urinary incontinence, therefore, childbearing may not be exposure. In men about to undergo radical prostatectomy or as part of a planned recovery program after childbirth or surgery. Most often, pelvic floor muscle training is used to treat existing urinary incontinence and may also be augmented by biofeedback using visual and tactile or auditory stabilizers such as technical stimulation or platform. Efficacy of pelvic floor muscle training in stress urinary incontinence, urinary incontinence, and mixed urinary incontinence women with question has been addressed by several SRs. All report inconsistencies between studies because of poor reporting of technique and different outcomes of treatment. Analysis showed that PFMT was effective for growth improvement of incontinence improvement. The fact applies in women with stress urinary incontinence due to identify both affecting urinary incontinence with lower the improvement with pure stress urinary incontinence. Cochrane reviewed comparing different approaches to delivery of PFM FMT in the one randomized controlled trials concluded that increased intensity of delivery of the therapy improved response and that there is no 10% difference between group therapy and individualized treatment time. No other transmission differences with the technique was found. With regard to the usability of EFMT, another article reported the 3-year follow-up from an early article showed that long-term adherence to treatment was poor and half of the patients had progressed was reduced. These reviews are confounded by differences in patient selection and have arrived at conflict conclusions, leaving uncertainty about the extent to which one treatment may augment the other. Similarly, there remains uncertainty about the additional value of biofeedback with SRC treatment samples. Comparison of EFMT to other treatments was extensively reviewed by both ASR and 2000, which considered additional non-randomized data as part of mixed treatment comparison and resulted in a number of different findings of those based solely on direct comparison. In conclusion, using revised methodology supporting the journal principle that greater efficacy was achieved by adding together different types of treatment and by increasing their intensity. Application of FMT in childbearing. Women with USL reviewed randomized controlled trials pregnant or postpartum women which included PFMT in one arm of the trial. Infant or urinary incontinence with pelvic muscle training in postpartum period increases the chances of continence at 12 months postpartum. PFMT in elderly. The effect of pelvic muscle training in women with stress urinary incontinence does not seem to decrease with increased age. Trials with older women with stress urinary incontinence that appeared both primary and secondary outcome year were comparable to those trials for younger women. While PFMT in men after the post-medical prospectively, and 2015 Cochrane reviews concluded that there was no overall benefit at 12 months post-surgery for men who received post-operative PFMT for the treatment of post-prostatectomy urinary incontinence, and that the benefit of conservative treatment of PPA remains uncertain. A meta-analysis within this review showed that a great proportion of men were dry from between 3 to 12 months, suggesting that the PFMT may speed recovery of continence. A subsequent study adds to this evidence. So this is the summary of evidence for pelvic floor muscle training for women with urinary incontinence and pelvic floor muscle training for post-prostatectomy urinary incontinence, which tells us that pelvic floor muscle training is better than no treatment for including urinary incontinence, well, in women with stress urinary incontinence and fixed urinary incontinence. High intensity supervised treatment regimes and the addition of biofeedback confer great benefit in women receiving PFMT. While short-term benefits of intensive PFMT are not maintained at 50 years follow-up, pelvic floor muscle training commencing in early postpartum period improves urinary incontinence in women for up to 12 months. Pelvic floor muscle training for post-prostatectomy urinary incontinence. Pelvic floor muscle training appears to speed up the recovery of incontinence following radical prostatectomy. Pelvic floor muscle training does not cure urinary incontinence in men post-radical prostatectomy or transurethral prostatectomy. There is conflicting evidence on whether the addition of bladder training gives a biofeedback increasing effectiveness of PFMT alone. Pre-operative PFMT does not confer additional benefits to men that are undergoing radical prostatectomy.
I think this is a topic for another presentation. I think it would be by Dr. Zishan. So we will leave it as such, but suffice it to say here that all these things that you are actually discussing are they come into the domain of a clinic, and that is known as bladder rehabilitation clinic. I have the experience of visiting a center out of this country, Pakistan, and there what they do is they have got daily a clinic which is actually run by a specialist nurse, and she happens to be a very senior person, and she was very much experienced in dealing with patients, male and female, who have got problems with continence. So either they were having neurological diseases like Parkinsonism, multiple sclerosis, Alzheimer's, and as normal as physiological conditions like post-pregnancy. So all these patients, they have to be classified, and then there is a treatment strategy, which is a conservative treatment strategy to rehabilitate the bladder function. So she has got everything from intermittent catheterization, which actually she teaches each and every patient how to do it, to biofeedback, to something called physiotherapy of pelvic floor muscle. So she was an expert, and she has got her own staff. So I happened to visit that place and spent some time there. And it was the first time in my life, and probably the last time, when somebody taught me how to teach a woman to self-catheterize. Just a simple catheter, which is a Nalatin catheter. Nobody had ever taught me in Pakistan earlier than that experience, and again later than that. So when you will be actually in the process of dealing with patients, then if you ask me, I'll teach you the same principle and the same technique which she taught me there. So there is always a point in learning something at any stage of life, and maybe there are certain things which we think that they are very simple. We can always do it. We can learn by just reading through the text, but it is sometimes very difficult to teach someone, and when somebody does it practically, then it is altogether different. So we'll come to that point when practically we are in the process of doing things. So this is a very important subject, just to emphasize upon that point. Yes, please.
Conservative therapy in mixed urinary incontinence is about 1/3 of urinary incontinence and mixed urinary incontinence. Of course, stress urinary incontinence and urge urinary incontinence has become more commonly used. In terms of evidence base, many studies include patients with mixed urinary incontinence, but it is rare for these studies to provide separate analysis of patients with mixed urinary incontinence. The summary of evidence tells about the pelvic floor muscle training appears less effective for mixed urinary incontinence than for stress urinary incontinence. Electrical stimulation is equally effective for mixed urinary incontinence and stress urinary incontinence. But the recommendations that are the most bothersome symptoms first patients with mixed urinary incontinence. Now I am going to come for pharmacological management. So coming to the pharmacological management, we start from antimuscarinic drugs. Antimuscarinic or anticholinergic drugs are currently the mainstay of the treatment of urinary urge urinary incontinence. They differ in their pharmacological profile. Example, muscarinic receptors and other modes of action in their pharmacokinetic properties. Example, lipid solubility, half-life, and their formulation. The evaluation of cure for improvement of urinary incontinence is made harder by the lack of a standard definition of improvement and the failure to use cure as a primary outcome. In general, experts note that over-treatment effects of drugs is usually small but larger than this. Dry mouth is a common side effect, low constipation, blood vein, fatigue, and cognitive dysfunction may occur. The major release of formulation of oxybutyrate is the archetype drug in the treatment of urge urinary incontinence. Oxybutyrate immediate release provides maximum dosage flexibility, including an off-label on-demand. Immediate release drugs have a greater risk of side effects than extended release formulations because of different pharmacokinetics. Our transdermal delivery system (TDS) and well developed for oxybutyrate gives a further alternative formulation. Another drug is diagnostic. The cure rate for diagnostic was not were not included in the AS article review, while the continence rates were 29 to 53% for telepharmacy compared to 17 to 18% for Facebook. Transcutaneous oxybutyrate, transdermal oxybutyrate has shown a significant improvement in modern episode and mutilations per day versus place one other overpopulation per continent was not reported as an outcome. Oxybutyrate topicalization was severe to place for improvement of urological incontinence with a higher proportion of participants being pure. Now, with comparison of antimuscarinic agents. Head-to-head comparison trials of efficacy and side effect of different antimuscarinic agents are of interest for decision-making in practice. Fasotretinoin results of an the results of an antimuscarinic trials of fasotretinoin 4 versus 8 suggested a larger therapeutic effect on urinary incontinence with the higher dose, but with more adverse events. No antimuscarinic agent improves fewer more than another agent. Dry mouth is the most prevalent adverse effect. Good evidence indicates that in general, higher doses of any drug are likely to be associated with the higher rate of adverse effect. Although your formulations of short-acting drugs and longer-acting drugs are generally associated with lower rate of dry mouth than immediate release preparation. Oxybutyrate immediate release showed a higher rate of dry mouth than tolterodone and trospium immediate release, but lower rates of dry mouth than terifenacin 15 mg daily. Overall, oxybutyrate here has higher rates of dry mouth than tolterodone here, although the incidence of moderate or severe dry mouth were similar. Transdermal oxybutyrate had a lower rate of dry mouth than oxybutyrate immediate release and tolterodone here, but had an overall higher rate of withdrawal due to an adverse infection. Terifenacin 10 mg daily had a higher rate of dry mouth than tolterodone. Fasotretinoin 8 mg daily had a higher rate of dry mouth than tolterodone 4 mg daily. These have been similar discontinuation rates were observed irrespective of difference in the effect of dry mouth. Doses have been given but the evidence rated was maximum dose level between treatment trials with a dose escalation element. This is the summary of evidence which is telling
Now, if you go back to the previous slide, Mehtab, you go back to the previous slide, yes. You see, terifenacin, it is not available in Pakistan, but you can have other drug, for instance, Solifin or Solifenacin. So it is the same thing. Oxybutyrate, yes, it is available, and it was the first and the foremost drug which was used 20 years back and it comes by the name of Ditropan. We still use it, we still have it, but as you have also pointed out in your explanation, that some of the effects like dry mouth and reduced perspiration more with oxybutyrate as compared to the newer formulation, and that is tolterodine. So we don't have physoterodine, we have tolterodine, and that is available with us. So slightly different formulations or names, but obviously now in the second decade of 21st century, we have got many options available to us as compared to maybe in the early 90s, when we have got only one or maybe just one drug, or we have to manipulate from different angles sometimes the bladder function. Yes, please.
Okay, sir. So this is a summary of evidence which tells that the limiting evidence that one antimuscarinic drug is considered an alternative antimuscarinic drug for the cure or improvement of urinary incontinence. While the high dose antimuscarinic drugs are effective to cure or to improve urinary incontinence with a high risk of side effects. Once daily extended release formulation are associated with lower rates of adverse effects compared to immediate release ones. All these immediate discontinuation rates are reported in clinical trials, and dose scaling of antimuscarinic may be appropriate to safety to improve treatment effect, although high rates of adverse effect can be expected. But the transdermal oxybutyrate trial is restricted with lower rates of time out Then oral antimuscarinic drug, but has a higher rate of withdrawal due to skin reaction. The recommendations are to offer antimuscarinic drugs for adults with urinary incontinence, daily conservative treatment, and consider expanding to each combination of antimuscarinic drugs will be possible. If an antimuscarinic treatment proves ineffective, consider dose escalation or offering an alternative antimuscarinic combination or mirabegon or a combination. If there is early review of efficacy of side effects of patients and antimuscarinic. Antimuscarinic against adherence and persistence. Most rates of antimuscarinic medications are short term, usually covered. Adherence is in clinical trials is considered to be much higher than in clinical practice. And the summary evidence tells us about that adherence to antimuscarinic is low and decreases over time because of the lack of efficacy, adverse effects, and of cost. Most patients will stop antimuscarinic agents within the first 3 months. Okay, coming to now mirabegon. So mirabegon is the first clinically available beta-3 agonist available in 2013. Beta-3 agonist receptors are the predominant beta receptors expressed in smooth muscle cells of the precursor and their stimulation is thought to induce precursor relaxation. Mirabegon has undergone evaluation in industry-sponsored phase 2 and phase 3 trials. 3 SRs have the clinical effectiveness of mirabegon. They reported that mirabegon at doses of 25, 50, and 100 mg. The results in significantly greater reduction in incontinence episode, urgency episode, and ejaculation frequency by 24 hours in placebo, with no difference in the rate of common adverse effect. The placebo dry rates in most of these trials are between 35 to 40%, 43 and 50% for mirabegon. In all trials, the statistically significant difference is persistent only for the improvement but not for the urinary incontinence. Similar improvement in frequency of incontinence episodes and duration for 24 hours was found in people who had previously tried and those who had not previously tried antimuscarinic agents. As showed that the mirabegon is similarly efficacious as most antimuscarinics in reducing urinary incontinence. The most common treatment adverse effect in the mirabegon was blood hypertension, which was reported by 7.3%, cases of meningitis to 4% UTI, with overall rates similar to placebo. In a 12 active control randomized report by mirabegon 50 by 100 mg versus tolteridone, standard ER4 mg, the improvement of efficacy seen at 12 weeks was sustained at 12 months evaluation in all groups. The reported dry rates at 12 months was 43%, 45%, 44%, and 45% for the mirabegon 50 mg, 100 mg, and tolteridone 4 mg respectively. Post-lecture analysis randomized control showed that clinical improvement observed in parameters of overactive genital severity translated to an improvement in HSP and efficacy is maintained in patients with more severe degree of urinary incontinence. There is no risk of QTC prolongation and electrocardiogram risk in popular pressure growth of 100 mg dose. However, patients with uncontrolled hypertension or cardiac arrhythmia were excluded from these trials. And there is no significant difference in rate of side effects at different doses of mirabegon. Data from the large Canadian private drug plan database suggests a higher adherence rate for mirabegon compared to antimuscarinics. Patients on certain concurrent medications, example metoprolol or metoprolol tell that due to common metabolism pathways, their medication doses may need to be adjusted. In case of patients taking metoprolol, blood pressure should be monitored after starting mirabegon and if necessary, metoprolol dosing changed. Evaluation for urodynamic parameters is then defined later outside obstruction pro and OIB concluded mirabegon 50 to 100 mg did not adversely affect voiding urodynamic parameters compared to placebo, while equivalence was observed for the tolteridone and mirabegon at 12 months. Although the incidence of diamond was significantly higher than tolteridone group, mirabegon treatment patients improved in objective outcomes may correlate directly to relevant OMS overactive period in TBC. And also the patient who had an inadequate response of sulfonylurea monotherapy with 5 mg demonstrated that combination treatment with mirabegon 50 mg had a higher chance of achieving clinically meaningful improvement in urinary incontinence as compared to dose escalation of sulfonylurea. There is some new evidence which is telling us that minoxidil is better than placebo and has efficacious as antimuscarinic for the growth of urinary incontinence. Adverse rates with minoxidil significant placebo patients and 15 and solid and more from addition of minoxidil than dose escalation of solid. Often administering the minoxidil would have been urinary incontinence with great conservative. Now I'm going to talk about antimuscarinic and beta the agonist agents, the elderly and the cognition. The trials have been conducted in elderly people with early important consideration, especially those include the multi-factorial etiology of urinary incontinence and elderly comorbidities such as cognitive impairment, the fact of co-medications and the risk of adverse effects. The events of antimuscarinic agents on cognition have been studied in more detail. Coming to oxybutynin, there is evidence that oxybutynin immediately may cause worse cognitive dysfunction in adults. Recent evidence has emerged from a perspective of our study showing to undertake cognitive deterioration is students with prolonged symptomatic medication with oxybutynin. While more rapid functional deterioration might result from the combined use of the polystrate inhibitors and antimuscarinic agents in elderly patients with cognitive dysfunction. Coming to the solifanicin, one pool analysis has shown that solifanicin does not increase cognitive impairment in the elderly. No age-related difference of the pharmacokinetics of solifanicin in different age groups was found. All the more frequent adverse events in subjects over 80 years of age were observed, but there is no cognitive effect on the healthy elderly volunteers as shown. In a sub-analysis of a large trial, solifanicin 5 to 10 mg improved symptoms of and 12 in people greater than 75 years who had not responded to tolteridine. In patients with mild cognitive impairment and greater than 65 years, solifanicin showed no difference in efficacy between age group and a lower incidence of most side effects compared to oxybutynin immediate release. These are some more drugs, tolteridine, darphenazine, prostaglandin, and paclitaxel. In tolteridine, there is no change in efficacy or side effect rate with the age have been reported although higher discontinuation rate was found for both tolteridine and placement elderly patients, while two randomized controlled studies in elderly monocylic patient had effect on time. Post-existing has shown the little effect of cognition. One non-randomized comparison showed lower rates of depression in elderly participants with tolteridine here compared to oxybutynin. Immediate relief. Darphenazine. Two randomized controlled trials in elderly population, one patients with early urinary incontinence, other in volunteers, concluded that darphenazine was effective with no risk of cognitive change measured as mammary scanning test compared to placebo. Another study of darphenazine and oxybutynin in elderly people concluded that the two agents had a similar efficacy, but that cognitive function was more often affected in oxybutynin in standard disease era. Coming to trospium chloride, trospium does not appear to cross the blood-brain barrier in significant amounts in healthy individuals due to the molecular characteristic ordinary amine structure and hydrogen properties. 2 EEG studies in healthy volunteers showed no impact from trospium, while tolteridine caused occasional changes and oxybutynin caused consistent changes. No evidence as the comparative efficacy and side effects profiles of the trospium in different age groups is available. However, there is some evidence that trospium does not impair cognitive function and that effective compared to placebo with the elderly. Coming to the paclitaxel, food industry of brand is controlled by confirmed the efficacy of 8 mg but not 4 mg dose in over 75 years old, while enhanced was lowered in over 75 years old group, but the effect on mental status was not reported. A more recent randomized controlled trial showed efficacy of paclitaxel in the vulnerable, identifying no difference in cognitive mental anti-incontinence drugs in elderly. Our studies contain velocity and placebo included women are pretty high weight with no age certificates or other. But these are background analysis of pool data from our study showed efficacy and safety of near background elderly patients. The applicability of evidence to general elderly population is there. It's not really how much the data from the pool analysis.
Just a minute about this deloxetine. As I was telling all of you earlier, that in the early part of 1990s and perhaps in the past beyond that also, we didn't have much of pharmacotherapy, uropharmacology with us. We have got little drugs that can have specific action on various aspects of urology. Those were the times when actually we have used drugs that have got as side effects something which we can take as the particular effect. For instance, this duloxetine is actually a drug which was used for as an antidepressant in patients with psychological problems because of its action, inhibitory action on serotonin and serotonin release. Somehow what its side effect is, it makes the person continent, so it keeps the person slightly in a drier mode, meaning to say there is no leakage of urine. So that is actually the side effect of the drug. But for a particular case in elderly people, we have been in the practice of using it. Not only this duloxetine, but also many other tricyclic antidepressants were used just for the purpose of dealing with incontinence. So those were the times when all these drugs which have got antimuscarinic activity, particularly mirabegron, which was recently in the sense in 2013 it was introduced all over the world. In Pakistan, perhaps it was introduced not more than a year and a half back. So it is rather a newer addition to the whole drugs that are available to us for dealing with these kind of problems. So you must always consider that there is an evolution and an improvement in dealing with patients through pharmacology. Yes, please.
Yes, sir. Applicability of evidence to general adult population. It's not clear how much data from the pool and arts can expopulate into a general adult population. Community-based studies of the prevalence of anti-status is the most helpful. When starting any reduced elderly patients, mental function should be assessed objectively and monitored. No consensus exists as to the best mental function test detected. While the cholinergic load and number of medications have anticholinergic effect on cognition should be considered. This is a summary of evidence which is telling us about diagnostic drugs are effective in elderly patients. And mirabegron has been shown to be efficacious and safe in elderly patients. In older people, the cognitive impact of drugs which have anticholinergic effect is stimulated by increased length of exposure, while oxytocin may worsen cognitive function in elderly patients. Soliphanicin, diltiazem, phenylephrine, and prospon have been shown not to cause cognitive dysfunction in elderly people in short term studies. And the recommendations are the long-term intermittent treatment should be used with caution in elderly patients, especially those who are at risk to have a cognitive dysfunction. Drugs for the special incontinence are here. Standards about the duloxetine, which is an activity of take up the neurotransmitter, serotonin 5-HT and norepinephrine. Cyclospinal cord, an increased concentration of 5-HT and any in the synaptic with stimulation. So all studies had a high patient with withdrawal rate which was caused by a lack of acid high incidence of adverse effect, including nausea and vomiting, dry mouth, constipation, dizziness, insomnia, somnolence, fatigue among all. So this is some evidence telling us about the duloxetine 40 amplifiers improved stress during contact. Duloxetine causes a significant gastrointestinal and side effects lead to a high rate of treatment responsibility. All of these symptoms are limited to the first week of treatment. These are the recommendations of duloxetine in selected patients with symptoms of stress and incontinence. Surgery is not indicated. Urology should be initiated and withdrawn using dose titration because of high risk of adverse events. Estrogen. Estrogenic drugs included conjugated acting estrogens, estradiol, tagolone, and raloxifene clean or use hormone replacement therapy. For women with a natural therapeutic menopausal treatment for urinary incontinence has been oral transfeminine vaginal route of administration. Available evidence suggests that the vaginal estrogen treatment with estradiol and ostriol is not associated with increased risk of coagulation and the way to hypertrophic vaginal systemic administration. Vaginal local treatment is primarily used to treat cases of vaginal atrophy in postmenopausal women. Simplified calculus for the vaginal estrogen therapy includes urinary incontinence in postmenopausal women in short term by given the local estrogen are impacted as an adjunct to the surgical urinary incontinence and systemic hormone replacement therapy with conjugate technique estrogen, the previously active. Incontinent women increases the risk of developing urinary incontinence versus the existing urinary incontinence. The recommendations for these are to offer long-term vaginal estrogen therapy support in urinary incontinence and symptoms of vulvovaginal atrophy. For the women using history for breast cancer, the physician oncologist consulted for women taking an oral contraceptive active disturbance as hormone replacement therapy for developing or experiencing worsening urinary incontinence discussed already hormone replacement of therapy. Advise women who are taking systemic estradiol who suffer from urinary incontinence that stopping the estradiol is unlikely to improve their incontinence. Okay, this is the vasopressin. This is the static and vasopressin of diabetic hormone can take orally, nasally, or by injection. Vasopressin is most commonly used to treat diabetes, hypertension, and used at night to treat non-aneurysm for hyponatremia. The use of vasopressin increases the risk of developing hyponatremia. The summary of evidence: this risk of urinary incontinence is reduced to 4 over to 3 oral vasopressin, but not for honest legal vasopressin does not include urinary incontinence. Never use of vasopressin may lead to hyponatremias. So these are the recommendations that telling us about to consider offering test of specification regarding occasional short-term relief from daytime. Urinary incontinence will inform them that this drug is not licensed for this nation. Middle plasma sodium levels in patients from desmopressin. Do not use desmopressin for long-term control of urinary incontinence. Drug treatment in urinary incontinence is again Tolterodone and acidity of patients for women with Tolterodone about 35 to urinary incontinence but not stress urinary incontinence, suggesting that the efficacy of Tolterodone for urge urinary incontinence was not altered by presence of stress urinary incontinence. Another 40 urinary incontinence in adults stimulated update March 2008 study was done on 1380 people who established that Tolterodone was equally effective in reducing urgency and urge urinary incontinence symptoms regardless of whether there was associated stress urinary incontinence. We are going to prone for fallacy. While Loxamine, one or the Loxamine is from 5 to 8% certified to the leaders that must be dominant, urgency dominant or balanced urinary groups. Loxamine was effective for improvement of incontinence and fuel in all subgroups. While Loxamine was found to have equal efficacy for stress urinary incontinence, mixed urinary incontinence in a randomized controlled trial following secondary analysis of respective subpopulation. The summary of evidence tells about the limited evidence suggests that the antimuscarinic drugs are effective for improvement of the urinary incontinence in components in patients with mixed urinary incontinence. Loxamine is effective for improvement of post-stress urinary incontinence, urinary incontinence in patients with mixed urinary incontinence. The recommendations are to treat the both volumes of different first infections with mixed urinary incontinence, offer antimuscarinic drugs for beta diagnosis to patients with urgency predominant mixed urinary incontinence, and consider offering the Loxamine for patients with mixed urinary unresponsive to other conservative treatments and who are not sick cure.
Thank you very much.
So this is all the medical management. Thank you.
Thank you
for your.
Right, so this is again an important subject, important in the sense that all these drugs, most of them, maybe 90% of them are available, probably with a different name, but it has got the same mode of action. many of the drugs are in use, and if we make use of the recommendations and the guidelines, then their judicious use will become possible, and it will be then more scientific in dealing with our problem. And as I was saying earlier, since we do not have many of the surgical interventions which are actually available for all these patients, sticking ourselves to conservative therapy and to therapy which has got a role for pharmacology is, I think, is the only thing that can be done, and perhaps for a lot of cases that solves the problem. And since that is the case, then it has got its importance. So if we know the drug dosages of the antimuscarinic agents and other agents, then it will be rather easier for us to manage our patients. And it's a bigger population of patients, mind you, that come to us with all these problems, particularly the female incontinence patients. So this is very important. So if anybody wants to say anything at this point, any clarification needed?